So from today we will discuss about the drugs that mainly control and regulate the different types of the female sex hormones. So firstly, let us start with the female sex hormones. What are the main two female sex hormones? One is the estrogen and the another is the progesterone. Now already you have read in the physiology how this estrogen and progesterone modulates the menstrual cycle, which needs to be again recapitulated because the different drugs, different hormonal drugs or its congeners mainly acts so that this menstrual cycle also can be regulated. So firstly, you know that menstruation, menstrual period or menstruation. Menstrual period is basically a cyclic pattern by which the slowing of the uterine lining, systemic regular slowing of the uterine lining happens by means of the menstruation. Menstruation starts from the menarche. Age of the menarche is in the adolescence and this menstruation stops at the menopause. Menopause happens around 40 to 50. Now this menarche to menopause, this is the reproductive life of the females, and within this reproductive life the main two hormones that mainly play are the estrogen and progesterone. Now what is this menstrual cycle? Menstrual cycle mainly starts from the day 1 of the menstruation and it covers until the next menstruation. Okay. So day 1 to day 4 is usually the menstruation. From day 5 the different phases of the menstrual cycle starts. So in the mid of the menstrual period there occurs ovulation from the adolescence. Okay. So from the menstruation the starting of the follicular phase or proliferative phase happens, and this follicular phase or proliferative phase is the first part of the menstrual cycle. That is, it starts from the menstruation until the ovulation. Okay. So from the menstruation until the ovulation, that is the first half of the menstrual cycle, is known as the follicular phase or proliferative phase of the menstrual cycle. And within this follicular phase or proliferative phase, the main hormone that acts is the estrogen. Okay. So after the ovulation, the next phase is known as the luteal phase. Okay. And within this luteal phase, the main hormone that plays is the progesterone. Now, how does the ovulation happens? So approximately 36 hours before ovulation, there occurs sudden increase of the estrogen level. And this increased estrogen level leads to a surge of the FSH and LH. Particularly this surge of the LH, that is the luteinizing hormone, leads to the release of the ovum from one dominant follicle. So this is known as the ovulation. So if pregnancy does not happen, so ultimately starting of the luteal phase occurs and the follicle becomes the atretic follicle. But if there is pregnancy happens, there is some changes of the hormone levels so that there will be thriving of the embryo. Okay. So let's start with this. Now this within the estrogens, there are three main types of the estrogen. One is the estradiol, one is the estrone, and another is the estriol. Estradiol or 17 beta estradiol, this is the main active hormone in the reproductive life of the females. Okay. Estradiol form, 17 beta estradiol form. So this estradiol form is converted to the estrone in some part, and this estrone becomes the predominant hormone in case of the females after the menopause. So after the menopause, the main estrogen is the estrone form. In the reproductive life of the females, the main estrogen is the estradiol or 17 beta estradiol form. It is clear? And another form is the estriol. Okay. So estriol, and this estriol is the main hormone during the pregnancy period. So during the pregnancy period, the main estrogen is the estriol form. So it is clear? Progesterone is there are different types of the naturally occurring progestine. Progestine is the generic name, and within this the main progestine that plays within the reproductive period of the females is the progesterone. Okay. The ovary is the major site for the release of the estrogen and progesterone biosynthesis in non-pregnant premenopausal women. And the fetoplacental unit is the major source of estrogen and progesterone in pregnant women. Okay. Now there are different types. These estrogen and progesterones are basically steroidal hormones. These are steroids. Now the main receptors of the steroids are the nuclear receptors. Similarly, for the estrogen, there are estrogen receptor alpha and estrogen receptor beta. These are the nuclear receptors. For the progesterone, there are progesterone receptor A and progesterone receptor B. These are the nuclear receptors. Apart from the nuclear receptors, there may be some membranous estrogen receptors also, wherein the estrogen also acts with some non-classical effects. And these receptors are mainly activated by different types of the co-activators and co-repressors. So this estrogen receptor is present in different areas of the body. This is present in the breast, this is present in the endometrium, this is present in the ovary, this is present in the bones, etc. So there may be some drugs that may preferentially act on some estrogen receptors on some organs as agonists and some other organs as antagonists. We have also developed these kinds of the drugs also. This is known as the selective estrogen receptor modulators. We will discuss about this. So the normal reproductive period, what we are discussing, the female reproductive cycle, the same thing. So this is what I am discussing. So this is the first day 1 to 4 is the menstruation. So from the day 1 the menstrual cycle happens. So if some drugs is given like that you have to start with the day 1 of the menstrual period. That means day 1 of the menstrual period means already the menstruation is happening. So it is clear. So day 1 to 4 of a menstrual cycle is the menstruation. From day 4 to usually around day 14 is the follicular phase or the proliferative phase. And after the day 14 there occurs the progesterone becomes more dominant and there occurs luteal phase. And here the lining up, building up of the uterine endometrial lining happens during the proliferative phase, and the lining is maintained and then the lining breaks down. When the endometrial lining breaks down, the menstruation happens. Okay. So menstrual menstrual cycle usually the average is the 28 days. But it usually varies from 25 to 30 days. But if the menstrual cycle is less than 21 days, so it is known as the polymenorrhea, polymenorrheic females. If it is more than 35 days, so it is oligomenorrhea or oligomenorrheic females. Usually the menstrual blood loss is approximately 20 to 30 ml. But if it is more than 80 ml per day, so it needs evaluation. Okay. So follicular or proliferative phase and luteal or secretory phase. The portion of the menstrual cycle before ovulation, as we have discussed, the developing ovarian follicle produces most of the gonadal hormones which stimulate cellular proliferation of the endometrial. And the luteal phase, or also known as the secretory phase, this is the second half of the menstrual cycle. The corpus luteum, that is the dominant follicle, becomes the corpus luteum, that produces the progesterone, and the endometrium becomes secretory rather than proliferative. That is, it is becoming shedding. Okay. So as the dominant follicle continues to grow, so basically there are different types of the, within the uterus follicles are there. This is present before birth in case of the females. But usually there will be a single lining of the granulosa cells in the follicles. But during the adolescence, some follicles become starting increasing in the number, and there will be more layering starts happening, more granulosa cells starts happening, and after the adolescence, due to the influence of the hormones, usually one follicle becomes dominant follicle, and that dominant follicles ultimately leads to ovulation in each cycle. Okay. So it secretes, the dominant follicle secretes high sustained level of the estrogen. And the combination of the high estrogen levels and the rapid rate of the increase of the estrogen level ultimately causes a brief feedback effect that stimulates release of the LH and FSH, what I have discussed. So there will be a mid-cycle surge of the FSH and then mid-cycle surge of the LH, luteinizing hormone, follicle stimulating hormone. So that stimulates the dominant follicle to swell. Okay. and to increase the activity of its proteolytic enzymes. So if you do some ultrasonography, you can see that just before ovulation, the dominant follicle is usually in the range of the 15 millimeter. So if it is less than 15 millimeter or if it is very less, usually the follicles will not be dominant and there will be anovulation. Anovulation, that is ovulation will not happen. That may need treatment. So approximately 40 hours of the onset of the LH surge, the follicle ruptures and ovulation happens. So estrogen increases. With increased estrogen greater than usually 200 nanogram, there will be surge of the FSH and there will be further surge of the LH surge, and that leads to release of the ovum from the dominant follicle. So if the oocyte becomes fertilized in the fallopian tube, now if pregnancy happens, if the fertilization happens, so it reaches the uterus approximately 4 days after ovulation, okay, and implants into the endometrium approximately 5 to 6 days after ovulation. So you can see approximately 4 to 6, that is 10 days. So after the day 14, within the 10 days after the day 14, there will be implantation of the embryo happens, okay. So the cellular remains of the ruptured ovarian follicle becomes the corpus luteum, that dominant follicle from which the ovum releases and from which the pregnancy happens, that becomes the corpus luteum, and this corpus luteum secretes high amount of the estrogen and progesterone. Progesterone is mainly the dominant hormone in the second half of the menstrual cycle, as I have already discussed. That causes the endometrium to switch from the proliferative to the secretory state. So the endometrium begins synthesizing proteins necessary for the implantation of a fertilized egg. So this corpus luteum begins synthesizing different types of the hormones, nutrients, etc. That leads to thriving of the embryo within the implanted embryo. The blood supply to the endometrium also increases to provide increased nutrients if pregnancy ensues. Now this corpus luteum have a lifespan of approximately 14 days, okay. So if fertilization and implantation do not happen within these 14 days of ovulation, so it may happen that there may be some fertilization, but implantation will not happen. So if the implantation will not happen, that also leads to abortion, okay. So if the implantation will not happen within these 14 days, so what happens? The corpus luteum becomes atretic. So it becomes atretic, it becomes shrinks and ceases its production of the estrogen and progesterone. The endometrium lining ultimately sheds. So ultimately menstruation happens, okay. So in the absence of the estrogen and progesterone, there will be inhibition of the gonadotropin is removed. That is the negative feedback effect of the gonadotropin hormones will be removed. Production of the FSH and LH increases and beginning of the another menstrual cycle happens. Now if fertilization as well as the implantation happens, the blastocyst, the corpus luteum, the blastocyst, that is the implanted embryo, also secretes the human chorionic gonadotropin, HCG. This HCG stimulates the corpus luteum to remain viable and continue secreting the progesterone. So it is clear? So ultimately what I am discussing, that after the follicular phase, at the main hormone that is active in the follicular phase is the estrogen, okay. So the estrogen begins rise, it starts rising after the menstruation, it starts rising, and just before ovulation this happens in the peak. With this peak level of the estradiol level, there will be a surge of the FSH and LH. So you can see this is the violet one is the FSH, this is the FSH, this is the LH, and this is the estrogen level, okay. So when there is estrogen level increases just before ovulation, there will be surge of the FSH level, but this is the surge is less than that of the LH, and this is quite high surge of the LH, and this LH surge usually starts 36 to 38 hours before ovulation, and the peak level reaches approximately 24 hours before ovulation. So with this LH surge, there happens ovulation. So ovulation means ovum is released, and ovum is released from dominant follicle. And how this one follicle becomes dominant? This dominant happen due to the recruitment of one follicle from the starting of one cycle by means of the estrogen. Now ovulation happens, ovum comes out, then starts the luteal phase or secretory phase. Now if fertilization happens, that is if the sperm comes and ovum and sperm ultimately leads to fertilization, after it usually takes approximately 3 to 4 days. And not only the fertilization is needed only for the viable pregnancy, it needs to be implanted. Okay. And this implantation usually needs another 4 to 6 days. Okay. Now within this 10 to 14 days, the dominant follicle is known as the corpus luteum, and this corpus luteum secretes high amount of the estrogen and progesterone and different types of the nutrients also. And this estrogen, progesterone, nutrients keeps this corpus luteum viable, okay, so that there will be no shedding of the endometrial lining. So what happens? So there will be no menstruation in the next cycle, okay, if there is implantation and pregnancy. And if there is no pregnancy, so ultimately the ovum comes out and ovum ultimately released to the menstrual blood in the next cycle. Because the corpus luteum ultimately becomes atretic because there will be no support of the increased estrogen and progesterone, because this increased estrogen and progesterone mainly is supported by the human chorionic gonadotropin that is secreted from the fetus blastocyst. So if there is no fetus, if there is no implantation, there will be less estrogen and progesterone. The progesterone cover, estrogen cover is withdrawn. So ultimately there will be menstruation. So it is clear. So in the next half, that is the secretory phase, the main hormone is the progesterone. So all these estrogen progesterone interplay is mainly regulated by the hypothalamus and pituitary. So hypothalamus, pituitary and ovary, they mainly act in synchrony so that there will be normal physiology is maintained. So from the hypothalamus, gonadotropin releasing hormone is released. It usually released in pulses, and that acts on the anterior pituitary. You know, from the anterior pituitary, the follicle stimulating hormone and luteinizing hormone is released. And this FSH acts on the growing follicle, and from this the estrogen is released. LH also acts on the growing follicle, as well as it makes viable of the corpus luteum, and from this corpus luteum more progesterone is secreted, and also some estrogen is also released. So ultimately this estrogen, increased estrogen at the mid-cycle stimulates the LH secretion, so there will be LH surge. This LH surge causes negative feedback effect on the anterior pituitary, okay, and this increased progesterone estrogen after ovulation again inhibits the FSH and LH secretion, so that there will be some negative feedback effect at hypothalamus and pituitary level, and ultimately this causes the synchrony of the different hormones and continuation of the menstrual cycle. So it is clear how the different hormones mainly plays the important role in the menstrual cycle and menstruation. So now coming to the neuroendocrine control of the menstrual cycle. In the early follicular phase, first there will be neuronal oscillator in hypothalamus. In the hypothalamus there are neuronal oscillator, okay, that leads to pulse generator. So the gonadotropin releasing hormone is released in pulses. This is known as the hypothalamic gonadotropin releasing hormone pulse generator, that fires at intervals with frequency of about 1 per hour. So burst of the gonadotropin releasing hormone is released. So this gonadotropin releasing hormone interacts on its receptor on the pituitary. So on the pituitary there are receptors for the gonadotropin releasing hormone, and ultimately by its action on this, that leads to release of the follicle stimulating hormone and luteinizing hormone. Now this FSH in particular causes the Graafian follicle to mature and secrete estrogen, as we have already discussed, and effects of estrogen on the pituitary are basically inhibitory. LH and FSH released are decreased, and inhibin is also released from the ovary, that also decrease the FSH level. So there are different other hormones that also decrease or increase the positive and negative feedback effects. In the mid-cycle, when the serum estradiol level is greater than 150 to 200 picogram per ml for approximately 36 hours, already we have discussed, that leads to sustained elevation, brief positive feedback effect on the pituitary to trigger pre-ovulatory surge of the FSH and LH, as we have already seen. So ultimately this mid-cycle surge leads to follicular rupture and ovulation in 1 to 2 days, and ruptured follicle develops into corpus luteum, already we have discussed. Large amount of the progesterone and lesser amount of the estrogen is released under influence of the luteinizing hormone. And in absence of the pregnancy, corpus luteum ceases to function and steroid levels drop and menstruation happens. So the same thing, time and again I am saying. So red one is the estrogen and the blue one is the progesterone. This is the graph throughout the menstrual cycle, how it increases and decreases. So again, it's in the endometrium and it is in the ovary. In the endometrium, you can see in the proliferative phase, there will be building up of the endometrial lining, and in the secretory phase, ultimately, there will be decreased and ultimately that will be secreted. Menstruation starts. In the ovary, there will be growing of the follicles. So one becomes dominant follicle, ovulation happens, then it converts to corpus luteum. And what is the fate of the corpus luteum? Already we have discussed, there will be two fate, either there is pregnancy or there is no pregnancy. So now coming to the estrogen, what we can use the estrogen, this hormone, can be used as a drug. So the development actions, what are the actions of the estrogen? Estrogens are largely responsible for the pubertal changes in the girls and secondary sexual characteristics. So all the secondary sexual characteristics in the girls are mainly caused by these estrogens. So if there is some hypogonadism, so there will be less secretion of the estrogen, so we can supplement the estrogen level. So it can cause growth and development of the vagina, uterus and fallopian tubes and contributes to breast enlargement. Contributes to molding of the body contours, shaping the skeleton, causing the pubertal growth part of the long bones and epiphyseal closure. So if there is hypogonadism, so there may be some problems in here. So there may be problems in the bones also. The skeletons become deranged if there is not sufficient estrogen released during the adolescent period. Growth of the axillary and pubic hair, pigmentation of the genital region and the regional pigmentation of the nipples and areola occurs after the first trimester of pregnancy, and this all happens due to the estrogenic actions. All this happens due to the estrogenic action. Estrogens also play important developmental roles in case of the males also. Estrogen deficiency, if it happens, in the males also estrogen is released, albeit in the small amount, but if there is deficiency, that diminishes the pubertal growth spurt and delays the skeletal maturation and epiphyseal closure. So the linear growth continues into the adulthood. So estrogen deficiency in men leads to elevated gonadotropins, macroorchidism and increased testosterone level, and that also leads to carbohydrate and lipid metabolism, and that leads to infertility also. So from this, you can say that estrogen is very important for the males in the adolescence also. If there is estrogen deficiency, that amount of the estrogen that should be normally released in case of the males, there will be derangement of the growth spurt, derangement of the normal reproductive functions, that leads to infertility also. Metabolic effects, long-term administration of the estrogen is associated with decreased plasma renin, angiotensin, converting enzyme, endothelin 1, etc. So these are the different other hormones that play in the metabolism. Estrogen actions on the vascular wall causes increased production of the nitric oxide, prostacyclin. These are the vasodilators. Okay. So ultimately that causes vasodilatation and beta atherogenesis. So if there is estrogen deficiency, so there may be more chances of the atherosclerosis and there may be more chances of the myocardial infarction, stroke or peripheral arterial disease. Estrogens alter a number of the metabolic pathways that affect the clotting cascade also. It increases the plasma levels of the cortisol binding globulin, thyroxine binding globulin, etc., which bind both androgen and estrogen. That is, the protein level is also becomes deranged. It increases bone mass. Already we have discussed estrogen is very important both in case of the girls as well as the boys for the growth spurt as well as the normal skeletal growth. Bone is continuously remodeled by the resorptive action of the osteoclast and bone forming action of the osteoblast. In the previous class already we have discussed how the osteoblast and osteoclasts happens. Again it is a cycle of the bone turnover. So estrogens directly regulate this osteoblast and increase the osteocyte survival by inhibiting the apoptosis. The major effect of the estrogen is to decrease the number and activity of the osteoclast. so that there will be less osteoclast induced bone resorption. Okay. Estrogen slightly elevated serum triglyceride and slightly reduced total serum cholesterol level, increase the HDL level, decrease the LDL and lipoprotein A level. That is, the lipid profile is also favorably benefited by means of the estrogen. So the major site for synthesis already we have discussed in non-pregnant premenopausal women, ovaries is the major site of synthesis of the estrogen. In pregnancy, the fetoplacental unit is the major site of synthesis of the estrogen. Minor or peripheral sites, apart from this, from the liver, from the kidney, brain, adipose tissue, skeletal muscle and testes also, estrogen is secreted in the minute amount. In the postmenopausal women, ovary-induced steroid synthesis declines. Estradiol is the most abundant estrogen in the premenopausal women, that is in the normal reproductive lifespan. Estrone is the most abundant hormone after the menopause and estriol during the pregnancy. Progesterone is mainly secreted in the luteal phase from the corpus luteum and also by the placenta. So these are the different types of the estrogen preparation. Now estrogen can be given as a tablet, as a transdermal preparation, as a cream or gel or by injectable preparations. Now what happens when we are giving the estrogen, unopposed estrogen action on the endometrium, on the breast, etc. can also lead to carcinogenic effect. So when we are using the estrogen in high doses, that may lead to endometrial carcinoma, that may lead to breast carcinoma like this. So we have to make a balance between the amount of the estrogen that will cause favorable actions on different areas without or less side effects. So estradiol can be given intramuscularly or depot preparation or transdermal preparation or cream preparation, and estrone or estriol can also be given, but these are the weaker estrogen. Synthetic steroidal estrogens are available like ethinyl estradiol, mestranol, quinestrol, tibolone. These are available as a therapy. Synthetic non-steroidal estrogen are present like stilbestrol, dinestrol, chlorothiazide, etc. And some conjugated estrogen, lesser used nowadays, can also be available. So the natural estrogens already at the first I have discussed. So estrone, beta, 17 beta estradiol and estriol. Of this, the 17 beta estradiol is the main hormone in the reproductive period, already I have discussed. Estrone after the menopause and estriol during the pregnancy. So estradiol is the major estrogen secreted by the ovary. So how this estrogen is secreted? Again, all this starts from the cholesterol, because these are the steroidal hormones. All the steroidal hormones are synthesized from the cholesterol. From the cholesterol, there are different pathways. You can see different pathways from the cholesterol. Pregnenolone is formed. From the pregnenolone, progesterone is formed. From pregnenolone, there will be 17-hydroxypregnenolone. From this 17-hydroxyprogesterone can also be formed. And from this pathway leads to formation of the cortisol. That is the other steroidal hormones. And from this dihydroepiandrosterone and androstenedione can also develop. And from this androstenedione, testosterone is formed. This testosterone by P450 aromatase is converted to estradiol, the main form. This estradiol, 17 beta hydroxysteroid, it can be converted to estrone. So from testosterone from androstenedione, this estradiol and estrone is formed. These are the steroidal hormones. The main from which these are formed are the cholesterol. From the cholesterol, all these are synthesized. So mechanism of actions already I have discussed. So there are nuclear receptors, estrogen receptor alpha and estrogen receptor beta, and from this the estrogen acts. There are different types of the co-activators, co-repressors. There are also be chaperone proteins. So there will be interaction of this and ultimately leads to variable effects on different organs and tissues. So pharmacokinetics, it is well absorbed orally and transdermally, but natural estrogens are inactive by oral route due to rapid metabolism in liver. That's why it has to be synthesized estrogen is to be given. Estradiol injected intramuscularly are slowly absorbed and exert prolonged action. Natural estrogen in circulation are largely plasma protein bound. Estradiol is converted to estrone and vice versa in liver. That is, this conversion mainly happens in the liver. Estriol is also derived from the estrogen and these are conjugated with glucuronic acid. So where this estrogen can be used? So if we can draw this is the lifespan of the females. So before the menarche, that is in the small girls, we can use the estrogen if there is delayed puberty. So if there is delayed puberty, that may happen due to the estrogen deficiency. So we can treat them with the estrogen. Next, within the normal reproductive period of the females, usually the estrogen is used not as a single entity but in combination with a progesterone. Low dose of the estrogen, we will discuss about this, as a contraceptives. So most common use of the estrogen in our society is as a contraceptive. Next is dysmenorrhea and dysfunctional uterine bleeding. So if there is some dysfunctional bleeding, dysmenorrhea and different other problems in correlation with the menstrual period or menstruation, that we need the estrogen. After the menopause, there will be sharp decrease of the estrogen, and that leads to different types of the adverse effect. So in some of the cases, we can do some hormone replacement therapy. After, in case of the menopausal women, mostly it is done between the age of the 50 to 60, under the 60 years. Menopausal hormone replacement therapy or senile vaginitis. In those cases, we can use the estrogen. So the two major uses of the estrogen are, one is the menopausal hormone replacement therapy in the postmenopausal women, and as combination of the contraceptive in normal reproductive age women. So the hormone replacement therapy for postmenopausal symptoms, postmenopausal women, mainly it is used so that there will be less osteoporosis. So prophylaxis and treatment of the osteoporosis, we can use the estrogen. Previously it was used commonly, but due to the adverse effects of the unopposed estrogen, it is now used only at the last line drug in case of the osteoporosis. To decrease the vasomotor symptoms. So during the perimenopausal period and after menopause, there will be hot flashes, there will be some irritability and different other problems may happen due to the hormonal imbalance, due to the sharp decrease of the estrogen, that we can treat with this. Some cardiovascular disease can happen, urogenital atrophy, neuroprotective, because some cognitive decline can also happen, that can also be improved with estrogen. Estrogen replacement therapy in primary ovarian failure, we can give. Dysfunctional uterine bleeding, already we have said. Dysmenorrhea, acne and hirsutism we can use, and some prostate carcinoma in case of the males we can also use. So first, hormone replacement therapy for postmenopausal symptoms. So osteoporosis, already we have discussed elaborately in the previous two classes how the osteoporosis happen. Postmenopausal osteoporosis is very common, and now we have the first line different types of the drugs that are more commonly used, like bisphosphonates we can use more commonly. So most fractures in the postmenopausal women occur in women without a prior history of the osteoporosis, and estrogens are the most efficacious agents available for prevention of the fractures at all sites in such organ. So primarily they decrease the bone resorption. So estrogen receptors are present on the osteoclast cells, they act on this, ultimately bone resorption is diminished so that there will be less calcium available in the plasma. Maximal benefit requires continuous use, and bone loss resumes when treatment is discontinued. So appropriate diet with calcium and vitamin D is also needed when we are treating them with the estrogen. Vasomotor symptoms. Decline in ovarian function in menopause is associated with vasomotor symptoms. Vasomotor symptoms means there will be hot flashes. Hot flashes may alternate with the chilly sensation. There may be some inappropriate sweating. Less commonly some paresthesias. That is some tingling sensation, numbing sensation in the peripheral limbs can happen. Treatment with estrogen we can give. Medroxyprogesterone acetate we can also give as a combination also. Apart from this, another drug that can also be beneficial is the clonidine. So alpha adrenergic agonist clonidine is that diminishes the vasomotor symptoms in some women, presumably by blocking the CNS outflow that regulates blood flow to cutaneous vessels. In the cardiovascular system, so mainly the incidence of the cardiovascular disease seems to increase in the postmenopausal women, particularly due to the less coverage by the estrogen, because estrogen is protective against the cardiovascular disease. So estrogens produce a favorable lipoprotein levels. So HDL is increased, which is the good cholesterol, LDL is decreased. Ultimately, that also causes more vasodilatation, that causes the increased release of the nitric oxide. that causes decreased release of the angiotensin and endothelin that causes the vasoconstriction. So that there will be vasodilatation, the blood flows easily, there will be less stress on the heart. So different trials, it has been seen that the incidence of the heart disease and the stroke in older postmenopausal women, if they are treated with conjugated estrogen and usually it is combined with the progesterone, was initially increased and then it is decreased. So combined therapy is usually associated with a decrease in heart attacks in younger women. Combined is usually the combination of estrogen and progesterone is used because if we are using unopposed estrogen, that can also lead to building up of the endothelial lining, building up of the lining in different other organs that can lead to carcinoma. But if we are giving progesterone also, that checks the unopposed action of the estrogen. So usually the combination of the estrogen and progesterone is used, be it in the hormone replacement therapy, be as part of the contraceptive. Vaginal dryness and urogenital atrophy, very commonly used. In case of the postmenopausal women, usually estrogen cream is used to decrease the vaginal dryness and urogenital atrophy because that may lead to itching, painful intercourse, swelling of the tissues in the genital region, pain during urination, urinate urgently, urinary tract infections, all this can happen. And also there may be some vulvovaginal atrophy. All this can be decreased if we are using the estrogen creams in them. But there are some adverse drug reactions of this hormone replacement therapy and also estrogen. Most common is the gallstone, there may be some uterine bleeding, there may be some mood changes, breast cancer, migraine can also happen, there may be some thromboembolism can happen. Tibolone is a 19 non-steroid, it is a synthetic compound developed specifically for the hormone replacement therapy so that the adverse effects will be lesser. It is converted into 3 metabolites which exert estrogenic and progesteronal tissues. It is usually 2.5 milligram daily. It suppresses the menopausal symptoms, lowers the raised gonadotropin levels, no endometrial stimulation, so there will be less chances of the endometrial carcinoma. Urogenital atrophy, psychological symptoms, libido, osteoporosis, all these are improved when used at tibolone. So tibolone can be used, which is a synthetic compound, adverse effects are less. Now there are some current conclusions regarding hormone replacement therapy. What happens? Previously, it has been seen that since they are estrogen deficient and we are supplementing with the estrogen, there may be some improvement of symptoms, different types of the symptoms in postmenopausal women. But different types of the clinical trials have shown that if we are using this hormone replacement therapy mainly in very elderly persons, so ultimately there will be deterioration because this estrogen also leads to different types of the adverse effects because estrogen leads to thromboembolism, estrogen leads to different types of the carcinoma. So the main indication of the hormone replacement therapy is the vasomotor symptoms and other types of the symptoms in the perimenopausal period. It should be used at the smallest effective dose, minimal dose of the estrogen. Most cases it is to be combined with the progesterone and for the shortest duration is to be used. Premature menopause clearly deserves the hormone replacement therapy. So it may happen that menopause may happen in some women prematurely. So in those cases we can use the hormone replacement therapy but in very minimal amount in very minimal period. Hysterectomized women should receive estrogen alone while those with intact uterus be given estrogen progesterone. Always remember. So if due to some dysfunctional uterine bleeding, due to some problems in the uterus, if there is hysterectomy, that is the uterus is removed, in those cases we can use the estrogen itself as it is. But if the uterus is intact, in most of the cases we should use the combination of the estrogen and progesterone so that there will be a balance between their actions. Perimenopausal women should be given cyclic hormone replacement therapy rather than continuous. It should be given in a cyclic fashion. It not is the best option to prevent osteoporosis and fractures. Already we have discussed there are different other drugs that should be given beforehand for the prophylaxis and treatment of the osteoporosis in the postmenopausal women rather than hormone replacement therapy. It affords protection against the coronary artery disease only in the early postmenopausal women, that is between the 50 to 60 or some early perimenopausal period. But in very elderly period, there will not be much advantage in using the hormone replacement therapy to decrease the coronary artery disease. Combined hormone replacement therapy at conventional doses, in fact, may increase the risk of venous thromboembolism myocardial infarction and stroke in elderly women, remember. Since they are causing the venous thromboembolism, so there may be more chances of the stroke and myocardial infarction, particularly in elderly, greater than 70, greater than 80 years, etc. It does not protect against the cognitive decline, may increase the risk of dementia, again in the elderly age group. Combined hormone replacement therapy increases the risk of breast cancer, gallstone and migraine. The need for hormone replacement therapy, that's why should be assessed in individual women and not prescribed routinely. So it is not like that just in the perimenopausal or postmenopausal women, since the estrogen is decreased, there may be some symptoms, you are just advising the hormone replacement therapy. So we have to assess the women, if the symptoms is very much more, like the vasomotor symptoms very much more, in those cases we have to use the hormone replacement therapy, particularly in the younger women, between the 40 to 50 or 50 to 60, in a minimal doses, most commonly in a combination with the estrogen and progesterone, and for the minimum duration of the time. So this is the current consensus about the perimenopausal and postmenopausal hormone replacement therapy. Okay. Now coming to the delayed puberty of the girls, it may be due to ovarian agenesis. Most commonly there may be some Turner syndrome or there may be some other syndrome that leads to delayed puberty. So in those cases we can use this. In both, the pubertal changes are brought about by estrogen treatment, except the rapid gain in height with growth hormone. So we have to add with the growth hormone, we have to give the small dose of the androgens also. Usually cyclic treatment is given, some prefer to start with a low dose and gradually attain the full replacement dose. So there may be some delayed puberty, the patient may come, in those cases we have to give this therapy. Dysfunctional uterine bleeding, unpredictable, painless uterine bleeding may happen, recurrence can be stopped. Usually we are treating this with some contraceptives. So contraceptives are not only used only for the contraception, that can also be used for treatment of different other diseases. We will discuss this in the next class. Dysmenorrhea, again we can use the NSAIDs and also the combination of the estrogen and progesterone. Carcinoma prostate, estrogen may be used as a palliative therapy that provide relief in primary as well as the metastatic carcinoma prostate. Okay. Apart from this, we can use the gonadotropin releasing hormone agonist with or without androgen antagonist that preferred. Senile vaginitis. So in case of the elderly persons, there may be some dyspareunia or urethral symptoms that responds to vaginal estrogen cream. Acne and hirsutism, if there is increased androgen secretion, we can again use some cyclic treatment of the estrogen progesterone combination. Topical therapy like antibiotics, retinoid also can be used with the acne or hirsutism. So these are the different indications for the treatment of the estrogen, most commonly the combination of the estrogen and progesterone. So what are the indications? The first indication is as a part of the contraceptives. The second one as the part of the perimenopausal and postmenopausal hormone replacement therapy. The third one is in case of the delayed puberty, in case of the girls. The fourth one is the different types of the uterine disease like dysfunctional uterine bleeding, dyspareunia. There may be some vasomotor symptoms, senile vaginitis. In some of the cases, we can use as a last resort for the prophylaxis and treatment of the postmenopausal osteoporosis, acne, hirsutism, etc., etc. So these are the adverse effects. In case of the males, when we are using, that can lead to gynecomastia, feminization and decreased libido, particularly when we are treating with, in case of the prostate carcinoma. In case of the females, already we have discussed, there may be some thromboembolism, breast tenderness, increased attack of the migraines can happen, withdrawal bleeding can happen, amenorrhea can happen, endometrial hyperplasia that may lead to endometrial carcinoma, risk of the breast cancer is there. If it is used in case of the pregnancy, that leads to vaginal and cervical adenocarcinoma in case of the female offspring also. So in case of the pregnant, we are using this, that leads to some vaginal cervical adenocarcinoma in female offspring. That can lead to this. In both sexes, it can lead to gallbladder disease, gallstone, some hepatic dysfunction, thromboembolic disorders. Onset of the diabetes can happen in some of the cases, fluid retention can happen. So these are the adverse effects of the estrogen. So carcinogenic actions of the estrogen already we have discussed. When we are using estrogen, particularly in very high doses, which is not used nowadays, that can lead to some breast cancer, that can lead to endometrial cancer, that can lead to cervical and vaginal cancer also. So estrogens ultimately used in very low doses So the use of the unopposed estrogen for the hormone replacement therapy or contraceptives is not used nowadays because it leads to chances of the endometrial carcinoma increased by 5 to 10 times. The increased risk can be prevented if we are combining this with a progesterone. Okay. So it is a contraindication when we are not using the estrogen therapy. If there is already some gallbladder disease, if there is some thromboembolic disorders already present, pregnancy already present, hepatic dysfunction, uncontrolled diabetes, estrogen dependent breast cancer, endometrial carcinoma already present, endometriosis, some undiagnosed genital bleeding, we have not diagnosed yet. So these are the contraindications. We should not at first give the estrogen therapy. We have to evaluate. Okay. Now coming to the selective estrogen receptor modulator. In the first, I am saying that there are different estrogen receptors in different organs. Now already we have seen that if we are using the estrogen, that may lead to some building up of the lining of the endometrium, that may lead to endometrial cancer, that may lead to breast cancer. So if we are using some types of the estrogen that have some agonistic actions where we need agonistic actions and antagonistic actions where we do not need any actions, that leads to a favorable benefit. Okay. So this is the selective estrogen receptor modulator, which gives some context specific and organ specific agonism and antagonism of the estrogen receptors. Okay. So these are the group of drugs which are the synthetic and these are the non-steroidal drugs. Tissue selective estrogenic and anti-estrogenic actions. The pharmacological goal of these drugs is to produce beneficial estrogenic actions in certain tissues like on the bones, on the brains, on the liver, and antagonistic action in tissues like the breast as well as the endometrium. So currently most commonly we are using these SERMs are the Tamoxifen, Raloxifene, Toremifene, and another is the Bajedoxifene. Okay. So these are the selective estrogen receptor modulators in use. So they exhibit estrogenic, anti-estrogenic, partially estrogenic actions depending on the receptors and organs as well as the tissues. Tamoxifen basically inhibits the proliferation of the cultured human breast cancer cells. That's why this tamoxifen and also tamoxifen mainly used in the prevention and treatment of the breast cancer. Okay. They have anti-disruptive actions on the bones, particularly the Raloxifene have anti-disruptive action and that can be used for the prevention and treatment of the postmenopausal osteoporosis. They also upregulate the TGF-beta. So you can see tamoxifen is basically a potent estrogen receptor antagonist at the breast, at the blood vessels as well as the peripheral sites. Whereas it is a potent estrogen receptor agonist at the uterus, bone, pituitary and liver. So it has antagonistic actions though it inhibits the human breast cancer cells and hot flashes. That's why it is mainly used in breast carcinoma. But again the side effect is there may be small chances of the increase of the endometrial carcinoma because they have agonistic action on the endometrium. So there may be some endometrial proliferation, there may be improvement in bone density, this is a favorable benefit. Decrease in the total and LDL cholesterol, this is favorable. No change in HDL and triglyceride and there may be some increase in thromboembolism. Increase in thromboembolism is common for all the estrogenic drug, be it selective estrogen receptor modulator or the normal estrogen. So it is effective orally, biphasic half-life 10 hours and 7 hours, 7 days. Major metabolite is the 4-hydroxytamoxifen, long duration of action. When we are giving, it is a long duration of action excreted in bile and stool. Side effects may be some hot flashes, vaginal bleeding, vaginal discharge, menstrual irregularities, dermatitis, increased risk of thromboembolism, depression, anorexia, etc. can happen. So mainly where we are using tamoxifen mainly causes the antagonistic actions on the estrogen receptor on the breast cells, estrogen receptor that is present on the breast cells. So in case of the pre and postmenopausal breast cancer, it is used. Primary prophylaxis of the breast cancer in high risk women. In some of the cases we can use in postmenopausal osteoporosis and in some of the cases we can use in the male infertility. But again tamoxifen if we are using it for a long period of the time, that leads to its adverse effect also. That is there may be increased chances of the endometrial cancer, there may be increased chances of the thromboembolism. Okay. Toremifene is a congener of the tamoxifen. More or less its action and indications all are similar to the tamoxifen. So both the tamoxifen and toremifene, these are used for the treatment of breast cancer. Remember, for breast cancer treatment, tamoxifen and toremifene. Okay. Raloxifene. Raloxifene is another selective estrogen receptor modulator. So here they have a different pattern of action than that of the tamoxifen. It is an estrogen partial agonist in the bones and the cardiovascular system, and it has antagonistic action on the endometrium and breast. So it has more agonistic activity on the bones rather than that of the tamoxifen. So mainly it is used to decrease or block the resorption of the osteoclastic bones, osteoclastic cells in the bones. So it has high affinity for estrogen receptor alpha and beta and has a distinct DNA target. So this acts on a receptor known as the raloxifene response element. So there will be dose dependent increase in osteoblastic activity and decrease in osteoclastic action. So when we are using raloxifene, that improves the bone mineral density and ultimately prevents the bone loss. It reduces the incidence of the compression vertebral fracture, which is very common in postmenopausal women. It decreases the LDL, no increase in HDL and triglyceride, does not stimulate endometrial proliferation. They have anti-proliferative action on the estrogen receptor positive breast tumor and the cancer-like cells. It can be absorbed orally, low oral bioavailability by large volume of distribution, half-life 28 hours and excreted in feces. Side effects again similar, like there may be some hot flashes, leg cramps, pulmonary embolism, deep vein thrombosis. That is, thromboembolism is common more or less. Mainly it is used as a second line drug for the treatment and prevention of the osteoporosis in postmenopausal women. Secondary prevention and treatment of the vertebral fractures. In very minute cases, it can be used as the treatment or prevention of the breast cancer and alternative to the hormone replacement therapy. So tamoxifen and toremifene mainly used for the treatment of breast cancer, and raloxifene is mainly used for the treatment of the osteoporosis, postmenopausal osteoporosis. Apart from this, there is another SERM known as the bajedoxifene, which is mainly also used in some of the cases of the breast carcinoma as well as the osteoporosis. Ormeloxifene is another SERM which is mainly used as a contraceptive. So this is estrogen antagonist at the breast and uterus. They have anti-estrogenic as anti-progesterone action. This can be used in dysfunctional uterine bleeding, apart from used as a contraceptive, and it is also can be used in some cases of the breast cancer, osteoporosis, endometrial cancer also. It is under evaluation. Again, the adverse effects minute, like there may be some nausea, headache, weight gain or fluid retention. So selective estrogen receptor modulator is very important. So it is clear. So selective estrogen receptor means there may be an estrogenic, anti-estrogenic actions or partial estrogenic actions on different receptors, different organs, so that there will be some context specific action. This happens due to the response, differential response of the different co-activators and co-repressors of these hormonal receptors, like the estrogen receptor alpha and beta. Of this, the most commonly used is the tamoxifen, toremifene and the raloxifene. Apart from this, there may be some ormeloxifene and bajedoxifene. Tamoxifen is mainly used in the treatment of the breast cancer. Raloxifene is mainly used for the treatment of the postmenopausal osteoporosis. Ormeloxifene is mainly used in case of the dysfunctional uterine bleeding and as hormonal contraceptive, and bajedoxifene is also used in cases of the breast cancer as well as the osteoporosis.